So you've already heard from me, but just to remind anyone who's joined late, my name's James Chalmers. I'm a chest physician in Dundee in Scotland. And I think we've done really well to get through most of today without focusing a lot on COVID-19, but it was inevitable. We needed to talk about this issue today. And so I'm very pleased that we have that opportunity. I'm very pleased also to be here with Thomas, who's my co-chair. Do you want to just briefly introduce yourself, Thomas?
Yes, thank you, James. I'm also, like Alan, a patient with only mild bronchiectasis. So I'll be glad to watch out what kind of questions you put into the question and answer.
Fantastic. So without further ado, because we're starting a little bit late, I'm going to introduce the first speaker. So it's my great pleasure to welcome Dr. Andrea Gramegna, who's from Italy, and is going to give us a presentation on COVID-19 prevention and symptoms. Andrea, thank you so much for joining us.
Thank you. So good afternoon, everybody. I'm so pleased to be part of this great meeting today. That's something really wonderful. And first, let me thank the organizers for inviting me as a speaker, and thanks to the panel for the introduction. My name is Andrea Gramegna. I'm a consultant and assistant professor of respiratory diseases at the University of Milan. I work with Professor Alberti, that is my mentor. And as most of you already know, my region in northern Italy has been so heavily hit by the pandemic at the beginning and till now, that now a large part of my clinical activity is dedicated to the treatment of COVID-19 patients in the setting of a high dependency cardiorespiratory unit. So this is my, I can say, my background to talk of this topic to you. And my speech today is divided into two main chapters: prevention of SARS-CoV-2 spread and infection, and the clinical spectrum of COVID-19. So we have only 15 minutes, so I will give you an helicopter view about these two issues, and I will try to give a special perspective towards people living with bronchiectasis. That's a disclosure I need to say now. Most of my speech is based on personal experience, both with bronchiectasis and COVID-19, since we still have poor data, a lack of data, it's better to say, a lack of data and scientific evidence about this possible interaction. Well, chapter 1 is about prevention. Just to have a shared definition, I pick the definition from a prestigious source, that is the World Health Organization, that defines two different types of prevention. The primary prevention has the goal not to get infected by the virus in this case, and is based on avoiding bad behaviors, promote right behaviors, the use of personal protective equipment, as most of you already know, and also is based on a vaccination program that can defend both on an individual and a community level, and I will spend a few words about that in the next slides. And then we have also secondary prevention that is based on early detection of the disease and test and trace strategy that is useful for limiting the negative effects of COVID-19 on individual level and to limiting the spread of the infection on a community level. Safe behaviors. At this point of the pandemic, I'm sure that all of you already know very well these simple strategies. This slide was needed, and it is just to mention the main rules. And regarding this issue, I would like to note that this is a personal experience, but I think it can be shared with the other. at the beginning of the pandemic, when the general population was barely unaware about masks and the right way to use them and all the other strategy of self-confinement, many of you, as expert patients, were already adopting those behaviors, those attitudes as part of your daily attitudes in order to avoid the risk of cross-infection. And so I think this can be the reason why, at least in my personal experience, at least with my cohort of patients, patients with bronchiectasis were rarely among the infected. Well, but as we know, the last frontier of prevention of COVID-19 is the vaccination campaign, and some countries is doing very great in vaccination. By now, several vaccines are currently being under development or experimented on volunteers. And now 3 of that vaccines have been approved for the clinical use in the European community. It's difficult to discuss here the different types of vaccines, their mechanism, and how they had been developed. But I think it's useful to focus our attention to an issue that rose a lot of doubts among both healthcare personnel and patients. That is the safety issue. The fact that the vaccine development process has been reduced from many years to 1-2 years has risen doubts about the safety among people. And this achievement depended from several factors not affecting safety. And I include in these factors some issues like the unprecedented financial investments, a faster authorization process, the experimentation of more than one vaccines in the same time, and new manufacturing platforms. However, all these factors did not make clinical studies less strict, less rigorous as they were would have been before COVID pandemic. And this is a simple table just to say that this is a summary of available phase 3 trials on vaccination on February the 5th of this year. And just to say that the most common adverse events that were documented in the vaccination group were of mild intensity, as flu-like illness, headache, injection site reactions, and so not so different from common adverse events for other vaccines more accepted or well known as the influenza vaccination. So safety is a prerequisite for a vaccine to be administered. A vaccine is not a drug for critically ill people, but rather a treatment to avoid that is given to those who are well, to healthy people, to prevent the risk of the disease, of the severe disease. So the evidence that we have now are based on high quality randomized clinical trials and highlights that vaccination is a safe intervention. My view is that now the big questions about COVID-19 preventions in the group of individuals with bronchiectasis are mainly 2, and the 2 following. First question, are patients with bronchiectasis at more risk to get COVID-19 than the general population? And my answer to this question is no. The infection can be caught by anyone with the same risk, but at least at the beginning of the pandemic, patients with an underlying lung condition as bronchiectasis have been suspected to have a more serious infection. And then we will spend a few words about that. Second question is, should patients with bronchiectasis be vaccinated against COVID-19? And the answer for this question, in my view, is yes. Individuals with a severe lung condition including bronchiectasis, should receive COVID-19 vaccination with a priority as a way to shield these patients against the infection. And this statement is based upon some recommendation published by health authorities in different countries or scientific communities, scientific societies. And just to mention one, the BTS, the British Thoracic Society, as an open mention of bronchiectasis as a lung condition, an underlying lung conditions that deserve this type of intervention. Then my second chapter, that is the clinical manifestation of COVID-19. I'll summarize the most common clinical manifestation of the disease in this slide. As you see, I try to divide clinical manifestation according to the probability to having, and the most common symptoms are fever and systemic manifestation of inflammation, that is asthenia, tiredness. Dry cough or cough is also a common symptoms that can be a sign of an early bronchial and pulmonary involvement. But as you know, COVID-19 is a viral infection, so we can have systemic symptoms as aches, pains, or also symptoms affecting other clinical manifestations affecting other organs and apparatus, as gastroenteritis, diarrhea, or eye or skin manifestations. Besides people with COVID-19 and clinical manifestation, we must remember that there is probably a very relevant group of people who does not have any clinical manifestation. This population, this group of asymptomatics, has probably a key role in the diffusion of the disease and can be addressed only by a secondary prevention with an early diagnosis, testing and tracing strategies, and quarantine. This is a key slide when we talk about COVID-19 clinical manifestation. This figure is about COVID-19 clinical course. This is something we had no bare idea at the beginning, in the few weeks where we were facing this disease in last March and April. And now we know that after a median incubation period of 4 to 7 days, that can be also longer, an infected individual can stay asymptomatic or can develop, in the majority of cases, clinical manifestation to mild to moderate infection. And please note that in this first phase, viral replication is predominant, and so clinical manifestation are those of viral infection. Systemic disease, systemic symptoms as fever, but also high skin manifestation, or those clinical manifestation of an upper respiratory tract infection, as cough, dry cough, for example. Then a pulmonary phase can develop, and in only a small portion of patients who develop pneumonia. And in this phase, the disease progression is not driven by viral replication, but is most driven by host inflammatory response. That is the inflammation that our immunity system produces to fight against the virus. In this case, hypoxia can be reported, loss of oxygen can be reported. And finally, a small proportion of patients may develop a so strong hyperinflammation that may progress to a life-threatening condition, that is an acute respiratory distress syndrome, a condition that is called ARDS, that you may have read in several sources. And in this phase, mortality is a real possibility due to several mechanisms as severe hypoxia, loss of oxygen, thrombotic complication, or multi-organ dysfunction. But if we have a step back to COVID most common clinical manifestations, we see that both systemic and respiratory symptoms are very shared with acute phase in bronchiectasis. A difficult point in the clinical management of individuals with bronchiectasis in this phase during pandemic is to discriminate between the outburst of COVID infection and a pulmonary exacerbation, in the case that the patient has a worsening of respiratory symptoms. As you see, a lot of symptoms can be shared and mislead the differential diagnosis. So the only safe answer at this point can be a nasal swab for SARS-CoV-2. This is an open issue that I think will be in the clinical management of bronchiectasis now, that I think it will be addressed by the next talk about clinical management. But now I think we have to face a big question that is very difficult to give an answer. So the question is, are patients with bronchiectasis at more risk to progress to severe COVID-19 disease than people who do not have bronchiectasis? This is a difficult question because we do not have any evidence about that. At the beginning of the pandemic, people with bronchiectasis have been suspected to have higher risk of severe disease. At that time, this was an expert opinion, and now we do not know so far better about this interaction. From one side, we can have a comparison with other diseases as cystic fibrosis. We have observational studies and case reports that show that community with CF, a community of CF patients has a low prevalence and also low mortality in comparison with what we had figured for this population 1 year ago. But on the other side, we must remind that medications that we commonly use in people with COVID-19 as high-dose steroids and some hospital setting as ICU setting may be contraindicated or more difficult to be managed for those people with chronic respiratory infection, severe bronchiectasis, and some form of loss of oxygen and respiratory failure. So in the absence of data, my answer will be that people with bronchiectasis should be selected and shielded with vaccination with priority because of their condition. And so this is, of course, to defend this and to protect this community from severe disease. This is my last slide. In conclusion, 3 key messages from my short contribution. First, please go on, keep use your protective equipment, keep use your right behaviors, because we are now in a turning point in the management of COVID-19 crisis, at least for people with an underlying condition. Second message, the clinical management of people with bronchiectasis now can be really more difficult than before. So rely on your self-management and keep contacts with your respiratory physicians and with your doctors. And third message, be confident and trust of the upcoming vaccination campaign. Vaccines against COVID-19 are safe, efficient, and may protect individually and also on a community level. So thank you for your kind attention.
Thank you very much, Andrea. Really clear presentation on the key issue of the day, which is COVID-19. We're going to take the questions at the end during a combined Q&A session with Felix. So Felix really needs no introduction. Felix has been a steadfast member of the bronchiectasis community for the past 10 years. Important member of the EMBARC steering committee, also leads the German bronchiectasis registry, which is called Prognosis. He's an expert in bronchiectasis, but also in cystic fibrosis, primary ciliary dyskinesia, NTM disease, and runs the clinical service in Hanover, which is one of the largest I would expect in Europe, and has been a major contributor to clinical research studies over the past 10 years. It's going to be fantastic to hear his thoughts on delivering care during the COVID pandemic. Thank you, Felix.
Oh, thank you, James. It's a pleasure to be here, and it's really a great event. And I need to put something clear just in the beginning. I'm going to talk about delivering bronchiectasis care during the pandemic, and not about delivering intensive care to patients with bronchiectasis. So I try to clarify the content of my talk beforehand with the ELF, but now I recognize that there are some uncertainties that remained, and so please excuse if I may disappoint your expectations. This is a very rapidly evolving field with daily news, and I try to pick up some aspects that came up to my mind. I have some disclosures to make related to research support grants from the industry partners that we work with, payments from clinical trials, mostly related to my institution. And as James already mentioned, I'm also engaged in a few honorary positions like the bronchiectasis registries. And I need to make a second disclaimer, as already touched. So in the absence of robust scientific evidence, the following talk represents my personal opinion and experiences today. So tomorrow can be completely different, and I make no claim for this to be complete. I was approached with some COVID-specific questions from patients beforehand, and I just want to make you aware, this is one of the slides that one of the other bronchiectasis experts showed just before Christmas at the World Bronchiectasis Conference in the keynote lecture on bronchiectasis and COVID-19. And this man with whom I worked together said nothing could be older than the daily news and nothing better than yesterday newspaper. And the same is true for COVID-19, although we have never ever experienced before such an amount of research being conducted. The outcome at the end is rather poor. The outcome with regard to knowledge, is rather poor. And we never ever had so much research being retracted from medical and scientific records as we have now. So this needs to be really consumed with great care. And now I just want to make you aware of that. So the outline of my talk is I want to talk a little bit about the importance of time and place. So what I'm telling you about is in our setting in Germany, and you really need to be careful when transferring this to your local setting and local epidemiology. This is one of the major things we learned about the corona pandemic, may be very different in different settings and at different times. And I'm going to tell you a little bit about how to keep a bronchiectasis clinic alive during the pandemic and the potential collateral damage that may arise when US patients refrain from visiting your doctors. I'm touching preventing and management of pulmonary exacerbations and the importance of continuing research as well. So there are a lot of overlaps with the talks you had before. And I want to keep up with the two questions that were one of them already addressed in the talk before, and perfect examples, two different speakers, two different opinions, and even now that we have million experts in Germany, probably more than we have COVID patients still. I'm going to talk about if bronchiectasis patients have a higher risk for poor outcomes, and which respiratory or ventilatory support they should receive in case of severe COVID-19. So now I want to raise a question, and maybe I can have some support from ELF here. If you as a patient with bronchiectasis, did you attend regular visits in your bronchiectasis clinic or with your specialist chest physician in the last 12 months? So please, I'm looking forward to your answer. How did you specifically managed yourself during the last year? Please vote now. Okay, I'm looking forward. It gives an impression how you managed over the last year. Maybe we can get some results back. Oh, great! That's fantastic to see. So the majority of you voted that you could get consultation by phone or video, and this is exactly the thing. So there are definitely risks in this pandemic, but there are also chances, and we made quite some experience with that. The chance to get your doctor on the phone or consultation via video, and we even could use that extensively during the first wave that we experienced in Germany, and we even could get a reimbursement from healthcare insurances for that. But in the second wave now, with the beginning of the second wave at the end of last year, we really came back a lot to seeing patients face to face. So this is what you probably are all aware. We are now stabilizing infection rates at a quite high level globally. The same applies to my setting in Germany, and it's extremely important to be aware where you are and what your local situation is. So I tell you a little bit about how we organized our bronchiectasis service. We are luckily to have quite new rooms. We moved in 2013, and with the corona pandemic being a threat not only to US patients but to us as healthcare providers, we very early took preventive measurements to allow only one patient without relatives. Exceptions are adolescents and children and disabled patients and patients that are completely new to us that need to have some support with them. For sure, we, as you probably all have experienced in your setting, put up these plexiglass shields at the welcome and also in the consultation rooms. We spread the waiting areas across our clinic, and a huge issue with regard to collecting the very important sputum samples arises from that we are not able to have the samples collected inside the clinic. So we recognize that we have a quite useful balcony attached to our clinic and on the first floor, and we now use that to have patients cough up their sputum samples. However, during the winter that abruptly ended just a few days ago, and in Germany, with heavy snowfall, we were not able to use that as well, and that may be demanding. But I want to make you aware that looking into your sputum samples is extremely importance in managing your disease. And these are the numbers of visits to our bronchiectasis clinics through the years 2018, 19, and 20. So we had really a breakdown in March and April, but we are so lucky to continue caring for our patients at about 80% of the years before. In dark yellow, we have here now study-related visits. That means for interventional randomized controlled trials. And as you see now, I'll touch that later on, this has decreased accordingly. But luckily, we were able to manage like that, keep on management like that. And I guess this is not the case in a lot of other settings. So what the concept with regard to prevention and management of exacerbations, we really remember to update patient self-management plans and even to complete immunizations against other pathogens like influenza and pneumococci. We provided almost all patients with emergency plans, including low-level antibiotic prescriptions according to sputum cultures for emergency self-administration. In the case of a pulmonary exacerbation, as you are aware, these antibiotics do not have any activity against SARS coronavirus 2, but may help patients to stabilize and to avoid hospitalizations, because an exacerbation may not in every be caused by coronavirus, even in those days. Interestingly, we until now see a lot less pulmonary exacerbations among our patients, in cystic fibrosis patients as well. And probably this is one of the other chances that this crisis brings along, that now all people around there in the populations know about protecting themselves and the others from being spit at with aerosols. So probably that is the reason why we see a lot less exacerbations. And if you have a look at typical pathogens that are detected during winter times, we have a lot less influenza and other viruses creeping around now that we all protect ourselves. And with regard to self-management planning, and I want to point out that it's worth approaching your doctors if they can issue certificates for prioritized vaccinations. We do that routinely to all our patients. In Germany, it's that the patients with chronic lung diseases can be grouped into patient groups with high priority. So we have a three-step approach, and they would be in step 2, even if bronchiectasis is not explicitly mentioned. And I want to touch the importance of continuing research. We now have the situation at our institutions that we have 7 clinical trials from phases 1 to 3 being ready to start for since a few weeks. Probably still this will take another few weeks until it really happens. And this is really not only a chance, but also troubling us, because now at the same time, a lot of clinical trials will need recruitment, and most of these trials target the same populations. In this slide, I show you the situation as it is for the clinical trials conducted in the area of cystic fibrosis. So in April last year, it came down to 0 almost, but creeped up since then, as safety of patients is also the major issues in clinical trials. Beyond efficacy, you can see that the safety issues have not been neglected even in the times of April last years. So what we call monitoring of the clinical data, that is that are required in clinical trials kept on, and also again chances that came up in conducting clinical trials in cystic fibrosis were that now the awareness of some of the procedures being conducted at home or at home visits or remotely is increasing, and probably this will be one of the lasting impacts beyond the pandemic, that we have to rethink our clinical trial management, and whether it's absolutely important to have the patient in the clinic for every month during a clinical trial, or if we can outsource some of the procedures to the patient's home, which would definitely make conducting clinical trials easier and more feasible with regard to patients. So let me make the turn to the question if bronchiectasis patients are at any high risk for poor outcomes in COVID-19. And as you can see from this slide, the question is, it depends. So it's really a heterogeneous disease, bronchiectasis, with a lot of etiologies beyond, and it will depend of mainly individual factors. And after I have been asked this question, I went to my colleague who in December told us that bronchiectasis patients have no increased risk, and I acquired his slides. I went through these slides, and as I have discussed previously with James Chalmers, this colleague told that showed data, not one single study from patients with bronchiectasis and COVID-19, but as James pointed out, we are used to that situation in research and in medicine. We are familiar with stretching together evidence from other areas, from other diseases where there is no evidence. So my colleague, I reviewed these slides. My colleague touched asthma and COPD and CF and interstitial lung disease and tuberculosis and influenza, but not a single study on bronchiectasis. And I want to show you my patient that bothered us a lot with corona in the last year, and it's probably the only patient that had a relevant COVID-19 I can remember among the about 650 patients that we chronically care for at our clinic. This is a 43-year-old man with post-TB bronchiectasis and chronic pseudomonas infection, and he was first hospitalized in May with pulmonary exacerbation of his bronchiectasis and hemoptysis. At that time, he was negative for coronavirus. In July, he came back again with pulmonary exacerbation and COVID-19, including now more, as the previous speaker, my colleague told before, with more specifically COVID-19 symptoms, with GI symptoms, and yet repeatedly positive PCR tests. Not long lasted until he came back in November again with pulmonary exacerbation, still being COVID PCR positive, or again, we cannot distinguish that, now at a quite low level of infectivity and with low virus yield. In December, this patient came back with pulmonary exacerbation, PCR negative. In January, this patient came back with exacerbation, still negative, and now we switched the management to preventive home IV treatment for 3 weeks, although the frequency at which we can do that is still unclear. So some of the, and this is only one study from the German setting pointing out the major risk factor for poor outcome, severe coronavirus infection requiring mechanical ventilation and death. So there are plenty of studies that show that age, cardiovascular disease, diabetes, renal failure, and obesity are risk factors. And there's this strange box, chronic pulmonary diseases, where mostly COPD may be in. So it's very hard to to really reason the risk for a specific disease like bronchiectasis from this data. So there may be a slightly increased risk with patients with chronic pulmonary disease, which is probably mostly related to COPD. And there are some of the, I want to point out two studies related to cystic fibrosis. Very early study from Spain, where 8 patients with CF had COVID-19, were infected by SARS coronavirus. And the incidence in this population was calculated and was reasoned to be lower than in the general population. And none of these patients died. And there was another study in cystic fibrosis with 181 people, including 11 ICU admissions, 7 transplant patients among them, and 7 deaths among them, with 3 of them being transplanted. And this study observed that among patients with cystic fibrosis, older age, diabetes, lower lung function, and organ transplant may be associated with a more severe course. So these studies were interpreted like patients with CF have not an increased risk for severe corona disease. But the same study has now been made an argument that patients with cystic fibrosis are explicitly mentioned to be prioritized for vaccination because, and this is a perfect example how the same data can be looked at from different angles, because compared to peers, that means to people not having CF at the same age, definitely people with CF had much higher risk for hospital and admission and much more comorbidities. Compared with peers at the same age, and the patient group, CF patient group, managed to have our government included CF explicitly to be one of the diseases to be prioritized at vaccination. So yeah, and there are some data about patients with PCD. There's a collection at the University of Bern in Switzerland, where so far about 600 or 700 PCD patients participated, with 21 being tested positively and 3 patients being hospitalized. Again, this patient group with PCD patient will be much younger patients with less cardiovascular diseases. And the only specific paper I found out on bronchiectasis is a study from South Korea, where researchers compared claim data from a national database with bronchiectasis patients and matched controls. There were about 8,000 patients with COVID. There were about 120,000 patients matched without COVID. And in the COVID cohort, the rate of bronchiectasis was very slightly, though significant, higher than in the matched cohort. And this publication reasoned a 22% increased chance of having bronchiectasis in the COVID-19 cohort. And they found that patients with bronchiectasis have a higher risk for receiving oxygen therapy. They had a higher risk for mortality and had a significantly higher risk for having severe coronavirus infection. So the conclusion was that the patients with bronchiectasis may be more prone to COVID-19 than without, and additionally had showed more severe clinical manifestations and poorer outcomes. But, and this is again a very nice example, again, patients with bronchiectasis were older and had more comorbidities, in particular non-pulmonary comorbidities like cardiovascular morbidities. So at the end, age and the degree of comorbidities remains the most critical factor. And from my personal view, I cannot see that patients with bronchiectasis are at increased risk, but I can't prove that with clinical data. This clinical data is currently being generated and collected through the European and international registries for bronchiectasis, and we need probably to be a little bit more patient until we have more robust data. So I wouldn't give too much on this paper from South Korea, which is the only one on that specific issue that I'm aware of. And the other thing, this is touched very briefly, and the simple again is it depends which respiratory ventilatory support should I receive in case of severe coronavirus infection. I want to briefly touch different modes of support. So here you see a young man with an oxygen nasal cannula, with oxygen high flow therapy, and with non-invasive ventilatory positive pressure support. These are the non-invasive techniques to stabilize patients. And here are some pictures with invasive mechanical ventilations. So this means when a tube is inserted into your trachea, and as you can imagine, this is not tolerated or poorly tolerated in an awake patient. So most patients receive that kind of treatment, which is considered life-saving in conscious sedation or analgous sedation. So they will receive heavy medication against pain and protecting them from recognizing what's happened. And we know, and there's absolutely, in my point of view, nothing new with regard of coronavirus, and in particular with bronchiectasis. We already know that patients who are in a kind of very unnatural status like that, receiving positive pressure ventilation for a prolonged time in a not moving in a kind of conscious sedation status, that these patients have poorer outcomes in general, and in particular if they have severe respiratory failure, acute respiratory distress syndrome. And I think that the question whether the question which kind of support is applied really needs to be addressed to the local setting, and it depends on your individual risk factors, mainly age, and with regard to bronchiectasis, etiology, comorbidity, medication, and so on. And it's worth for you as a patient to think about healthcare proxy planning in general, absolutely regardless of the pandemic. It was just the shocking pictures where resources were short during the first wave in mainly northern Italy and in New York in the US, where the shocking pictures came up to the public, that resources were absolutely limited, and there had to be a triage which patient had the chance to get a ventilator and which patient not. And with regard to the higher risk, I think, to summarize, again, this depends on your local setting and on your individual risk factors. And I want to make a point that it's absolutely important to continue with your long-term bronchiectasis care, in particular, including physical activity. So when I look at my smart phone or smart watch, I do, even not being a patient and even not working in home office at all, I have less steps in 2020 compared with the years before. So it's absolutely important to continue with that, including clinic visits wherever safe and possible, and take the chance, address your physicians to optimize or update your self-management and emergency plan. And I want to repeat from my previous speaker, get vaccinated. We have such wonderful vaccines, probably never ever had more effective vaccines than before. And I'm happy to take questions thereafter. Thank you.
Wonderful, Felix. Thank you very much for that presentation. Has generated loads of discussion. Showing your pictures of the clinic rooms from Germany generated about 5 minutes of the UK and the the UK clinicians and patients saying we all want to move to Germany. So I'm going to hand over. Is Thomas there to ask a few questions?
Yes.
Fantastic. Do you want to kick off the questioning? Andrea, can you switch your camera on as well and join us?
Okay, thank you, James. Yes, as we've had two presentations that addressed the same issue. The first one said it was suspected, and Dr. Ringshausen has kindly picked up that question as well. So James and I concluded that that one has to operate on the precautionary principle because the data are not really in. One of the questions was about mRNA vaccines and the spacing of the first and second inoculations. Would anybody like to comment on that?
Yes, so mRNA is a new platform to develop vaccines. And the idea is that to give to the cells, to the immunitary system, not the virus and let the immunitary system do its work, but to give to the immunitary cells the project of that antibody that you want, that you think is the most effective to fight infection and severe disease. In this case, you can give to the cell a little piece of DNA, or in other case mRNA, just to let the cell to produce huge copies of that antibody. And the second inoculation is to give, is quite common in for vaccination, is to burst immunitary response against the antigen you provided.
Okay, I hope that answers the question. Another question that came up was, how should a patient determine whether he's having an exacerbation or whether he has COVID-19?
As I said in my presentation, this can be very difficult because a lot of symptoms. Can you? Okay, sorry, I plugged. So this can be very difficult because a lot of symptoms and clinical manifestation are shared between COVID-19 and pulmonary exacerbation in bronchiectasis. In most of cases, we have dry cough in COVID, but I think that if a patient had chronic sputum production because it has bronchiectasis and gets a COVID infection, a SARS-CoV-2 infection, he can have also a worsening of his or her chronic symptoms, including sputum production. So, in my view, this is a moment in which it's important to have the possibility to share opinion and to have the advice of your physician, because in most of cases you need the only test that can give you the right diagnosis, that is the swab for SARS-CoV-2.
So
yes.
If I may add on that, so I think we need to come back to really define what we talk about. COVID-19 is a quite defined disease, and not every having infection with SARS coronavirus 2 is developing COVID-19. So this has been like, now COVID-19 is everything. So I think patients experience that infection with SARS coronavirus 2 is another differential diagnosis, like infection with influenza virus or respiratory syncytial virus has been in the past, is another differential diagnosis for patients suffering suggestive symptoms of exacerbations. So it depends on your severity, whether you're going to test that, and every patient that comes with comes to the hospital with a pulmonary exacerbation of bronchiectasis will nowadays be tested for that. So you probably will not be able to find out if you are going to test. And there are patients, as I showed, experiencing pulmonary exacerbations due to infection with SARS coronavirus 2, and they are not having COVID-19 in the more narrow sense of definition.
If we wanted to go on to another question, Mrs. Atkinson was asking whether it's possible that COVID worsened her bronchiectasis. That was her experience.
Definitely, we have not been talking about the consequences of COVID-19, the so-called post-corona syndrome. Definitely, we know that patients, even those not experiencing severe coronavirus infection, may suffer from general symptoms, systemic symptoms like mainly fatigue and increased shortness of breath, which has a significant overlap with the chronic symptoms of bronchiectasis anyway. So definitely this is positive. And as Andrea pointed out, the major effort should be made not to get infected, because if you get infected, the disease may take an unpredictable course, with consequences even after having acute infection.
So we've only got a minute left because we'll have to move on. Can I finish? You know how I love to finish on an optimistic note. Do you think we've learned anything from COVID that's going to help us going forward? I'm thinking about more virtual clinics, what we've seen with sort of reductions in other viruses. A sort of final thought from both of you, if you've taken any lessons from COVID that might improve how we do things in the future. Felix, go first.
Yeah, as I pointed out, I think there are some chances for research and for routine clinical care, including telemedicine infrastructures that we now use more easily. We're now well equipped to provide this, and general protective measures. I think this is also of importance in the general population, but specifically in patients with chronic respiratory diseases. And maybe this was one of the strategic advantages that patients with cystic fibrosis or PCD had, because they have been used to these protective measures and hygienic methods before the pandemic.
And final thoughts from you, Andrea.
Yes, I do agree with Felix. We now have some sort of virtual clinics that before was not in our projects, and the most important thing is also that the health authorities now see that strategy as something to be implemented and to work with to improve, so easier to have.
Fantastic. Thank you both so much. Thank you to the audience for so many questions. That's been a really great session. And thank you, Thomas, for leading the questioning. We're now going to hand over to the ELF Patient Advisory Group for the final session, which is called Get Involved.
So over to you, Keld and Bridget.
Jess, can you hear me?
Yes, we can hear you now. We couldn't hear you before.
All right, that's fine.
Yes, we hear you.
Lovely. Hello, it's Bridget back again, and thanks very much to everybody. It's been, James was ending on an optimistic note. Speaking personally, I think there have been a lot of optimistic notes throughout this day, and it's been a lot to do with all the presenters and so many of you for asking questions and getting involved. But now we're coming to the end of the day, and we really hope that you've enjoyed it and found it useful. and gained helpful insights into managing your bronchiectasis. And before we ask the session chairs to join us for some final messages from the day, we'd like to show a short 3-minute video made by some members of the Bronchiectasis Patient Advisory Group. It tells more about why they got involved and how they found that. And Jess, if you could show the video.
It was a disease that I had never heard of before, and I didn't know anyone who had it either, of course.
Almost everyone knows what asthma is, but to explain bronchiectasis isn't that easy. So I normally never do that. I always say I have a lung disease.
I found having bronchiectasis quite lonely because there's not many of us out there, certainly not that I know of.
I discovered my bronchiectasis in 2015, and since then I had been searching for other patients like me to share experiences with.
It was really difficult to find a lung physician who had a real knowledge about bronchiectasis. When I finally found it, he introduced me to ELF.
And when I literally stumbled across the ELF online one day, I couldn't believe that there was actually people out there who were not only looking into it and researching it, but cared what I thought about my condition.
I joined the Patient Advisory Group for Bronchiectasis in the European Lung Foundation in 2015.
To finally meet people who have the same disease as you have, facing the same issues you have, talking to them gives you a lot of support.
I suppose the first thing I got involved in would have been answering surveys, and it was amazing to see questions asking me how I felt about my exacerbations, my condition, my treatment, and I remember regaling my family with great excitement at the fact that this organisation existed.
I actually attend 2 patient advisory groups, the COVID-19 and Bronchiectasis one, helping releasing new surveys, filling them, and also giving a hand for organization of events online like this one you're watching now.
Since joining ELF, I have managed to attend lots of the European respiratory conferences, which has been very good in seeing what's happening with the future. And with the future, we can have an influence on it.
I got the opportunity to go to the ERS, the European Respiratory Society Congress in Madrid in 2019, and actually to meet some of the ELF people on the patient advisory group with me, which was wonderful to see firsthand how much they care about the patient's experience.
And we've also been spreading the word through the websites, through published articles, and I'm fortunate enough to be involved in writing 4 published articles.
I feel so relieved that I can be involved and listen, being also a messenger between my Italian association and ELF.
Helping putting bronchiectasis even more on the map. So perhaps they can find better medicine, better treatments, perhaps even a cure for this disease. That would be really, really great.
For me, the ELF is wonderful because they really understand that I'm very limited in the time that I can give to projects, unfortunately, and it's very flexible in that way.
But it's not all heavy lifting. It's not all going to international conferences, partying, staying out late and making great friends. It's simple things like reviewing some of the literature, how to travel, guidelines, simple things which when written by doctors aren't always immediately understandable and usable by patients.
So I would urge people to get involved with the patient advisory group. It's a really nice, safe space to make your feelings known.
We are so lucky to have so many researchers working just for our group, and this is something you can be a part of.
And you can make a real difference.
Welcome, benvenuti.
We hope that this might inspire and encourage some of you to think about getting involved yourself. And you can keep in touch with us through the links on the slide. So you can sign up to the ELF newsletter. You can get involved by emailing us at the email address info@europeanlung.org. And you can look at the Bronchiectasis website. And that is coming soon in Dutch and French. And just another reminder to participate in the Bronchiectasis survey, which is open until the 7th of March, by going to the SurveyMonkey link or scanning the QR code. And we very much hope some of you will be in touch in these ways. And now back to Kjeld.
Yes, thank you so much, Bridget. So at this time, I would like to invite the session chairs to turn on their video cameras and their microphones, and then join me to share very briefly their impressions of the day and offer a few take-home messages. So I hope the session chairs are able to join me.
Right. So if I may start, it's absolutely fantastic to see so many patients involved. And I really want to make the point, be aware that you as patients have a tremendous power to put on authorities, and you should not be silent, and you should not be confident with the situation that there's no approved treatment, and that the responsibility for getting treatments approved is passed on to the pharmaceutical industry. So you really need to make authorities and your national representatives aware that you are not few, that you are many of you, and use the chance that's in an organization like the ELF.
Excellent. Thank you, Felix. So if I can ask then if Arietta is on the call and Tove to share a few insights.
I think this conference has really been terrific, and it really encourages me to keep working with the national patient organizations in Scandinavia to bring the bronchiectasis into the light and get us more information about it. Spread the information. It's really been great. Thank you for a great day.
Thank you. And can we hear if Barbara and Peter want to share some take-home messages?
Yes, I think it's been great because this whole program was put together by patients for patients. These were the questions that we wanted answered. And it's been great to connect with the absolute experts in their field from all over Europe, and to welcome patients from all over the world for the very first conference of its kind. And so I'm very grateful to you all. Thank you.
So thank you. And can I hear maybe if James and Thomas are ready to share?
Thomas, do you want to go first?
Yeah, thank you. I'd just like to say that I'm very pleased with the way that we all interact, both the researchers on the one hand and the patients on the other. My question has been addressed. I know the answer is not easy, but we found a solution. The answer is that we're applying the precautionary principle as we go forward. We don't want to get COVID and bronchiectasis simultaneously. Thank you for all who have all cooperated on this venture.
So from me, I think it's been an amazing day. 15 years ago, the ERS White Book described bronchiectasis as the most neglected disease in respiratory medicine. And I think you've seen today that it's not neglected anymore. And an enormous amount of that progress is due to the work of the patient advisory group, the ELF, and the people that have made today's conference happen. And I think it's really exciting to think about the progress we can make in the next 10 years as we work together towards better treatment for everybody with bronchiectasis. Thank you so much for the work that's gone into today.
So thank you. So I just then want to end this conference by saying a big Thank you to all our fantastic session chairs. And of course, also please join me in offering your gratitudes in thanking all our amazing speakers and the members of the EMBARC steering committee, members of the ELF Bronchiectasis Patient Advisory Group, and of course also our outstanding ELF staff who work behind the scenes to support this event. Last but certainly not least, I would like to thank each and every one of you for joining the event. So let's not forget that sharing is caring, and pay special thanks to those of you who have also shared their knowledge, both in this event, but also about this event, and invited others to have the opportunity to join the event. And as we are recording this event, talks will be made available on the ELF website next week, and also on the new ERS respiratory channel. So feel free to watch or rewatch the event there from next week onwards. So we'll, of course, also be curious to know how you have experienced this first ELF EMBARC Bronchiectasis Patient Conference. So a short feedback form will be sent to you and everyone who registered for the event. So please complete it, share your experience, and let us know if you want to be kept in touch about future bronchiectasis projects and events. So with that, and on behalf of my brilliant co-hosts, Bridget Harris, myself, everyone else involved in the conference, it is goodbye for now, but please stay in touch for the time to come.